Okay, so we're going to get started to honor everybody's time. Can we pull that door? First and foremost, I would like to say a very special thank you publicly to Mr. Tucker Woody for service on the training team, for you guys that had him, that were blessed by him on your shift. He did an incredible job for us. Needed to make some moves to come to days, so it's going to be a great miss for our department. And but personally and publicly, thank you very much. Dilly, yeah. So guys, in order to help us cover our national registry and our state requirements, we got to talk about trauma today. It's better than OB. Some of the objectives today, we're going to look at a couple of patient care reports that talk about hemorrhage control. We got to meet certain guidelines and talk about certain things through the year. So we're going to talk about some hemorrhage control and what those patients' outcomes were for things we did with tourniquet use. We want to discuss the management of spinal injuries in patients in the pre-hospital setting, and then we want to understand the principles of some of our MCIs. All right, so where did the tourniquet start? Well, many years ago. For those of you that have been in EMS or fire any amount of time, you have probably heard that tourniquets go and come 19 times in your career, because about every year, every other year.
So as we start to look at the process of the history of the tourniquet and how that tourniquet was used, we start to look back in 300 BC when the Greeks had a battle and they acquired some Hindu physicians. And as what they were seeing from these Hindu physicians is they introduced extremity tourniquets to the Greeks, but not used for hemorrhage control. Instead, the purpose was only used at that point for venomous snake bite treatment. So as that process continued over the years, and this is starting to explain why they've gone back and forth with tourniquet use, even in that same time frame of 199 BC to about 500 AD, Roman surgeons used bronze thigh tourniquets to use for significant bleeding control only during application for the limb amputation process. Even the fancier models, as you can see, were actually bronze with a little piece of leather inside to help with the comfort of the patient. So later on, Roman surgeons changed this practice, and they decided these tourniquets weren't all that great that they were using, because they felt like it was actually squeezing the blood out of the body, which was causing more harm. So through the years, tourniquets have endured a long history of being embraced, and they have benefits, and then they would determine that they didn't have any benefit, and it became an evil tool of death. So the saga continued and went back and forth. Then in 1718, a French surgeon, Dr. Petit, improved this tourniquet to a screw-type device, which mimics a lot of our cat tourniquets today. This was commonly used still only for surgery, not for emergent bleeding control. The American Civil War in 1860, they found on both sides of the battlefield that some people were very opposed to using it, and some were very prominent to use that for bleeding control in the field and for surgery practices. It took the recent war in the Middle East to where it finally got vindicated, and there are plenty of surgeons though that still say, you know what, it still induces there's a toxic state to that, and it still may cause harm. So the reason why this continued to go back and forth, and some of the physicians talked about that toxic problem from that extremity, is that during World War II, the Board for the Study of the Severely Wounded correctly attributed severe hemorrhage, that this definitely was a contributing factor to shock, but they also suggested that a patient could lose up to 75% of their blood volume and still recover, which we know was wrong information at that time. They also suggested that tourniquet use allowed toxins to develop and accumulate, and this would eventually kill the soldier from the toxins. Not exactly the hemorrhage was the cause. It wasn't until the 1990s where they were able to use computer analysis, and they were really able to examine this tourniquet application and tourniquet use, and most of this data came from Vietnam, and it confirmed the facts that most deaths were actually caused by uncontrolled hemorrhage. This was preventable death. For the first time, we had a computer-based, evidence-based practice to this process. This would help bring the tourniquets back to the forefront and in the community, into the medical community, and we were finally able to start recognizing that they were good.
And so for civilians and from the military, they were learning that death was causing 30 to 40% of these patients were bleeding to death, secondary to just not having it controlled. And so they really started to see, man, that's a large number that we can control if we can just get a device that will work good. Existing literature estimates that 20% of the deaths were preventable. Now, if you look at the Stop the Bleed campaign that's nationwide teaching to schools, it recommends that 43% of those children that died at Sandy Hook had injuries that were preventable death. Now, unfortunately, the teacher a lot of times was deceased in the room, and there was nobody to do basic bleeding control. But 43% of those kids could have had, by autopsy, had a chance. They were survivable injuries because of extremity injuries that we could have prevented that if we could have been aggressive with our junctional and extremity trauma. So we got to outweigh the benefit, because a lot of times we know when we put a tourniquet on, once again, that we have toxins, that we have stagnant blood in the extremity. There's a process of how they take those off, and a lot of it depends on how long it's been on and what the surgery was like to correct. Now, Dr. Brooks has even suggested at some point, you can go 6 hours out with extremity and a tourniquet in place, but it's a very long process of getting that tourniquet removed. So this was a study that came out of Houston Memorial, so right here in Texas. They had 105 patients that received a CAT-style tourniquet. Either pre-hospital was 78% of them, or at the ED was the rest of them. 10% of the patients really didn't even need them for the type of injuries, but this is going to be important here in a little bit. So the outcomes of this study was acute renal failure. 3 patients ended up having that, but it was not due to rhabdomyolysis. That is a secondary cause. That can be some of the problems when the clots start to come back through. They start to infiltrate the kidney. That can cause some rhabdomyolysis. The 3 patients that went into renal failure during that was not from rhabdo. So that was a good thing for the tourniquet. Compartmental syndrome. So remember, one of the biggest things we've got to do is we've got to occlude the blood flow completely, so we don't allow blood flow and then the retraction where it's not able to come back on the venous side, and we just get it bigger and bigger and bigger, and we end up having compartmental syndrome. One was post-cardiac arrest with delayed transfer to the study hospital. The second patient had the tourniquet removed and his limb stabilized with a improperly fit splint, and the compartment syndrome did not start till 6 hours after the new splint was in place and surgery was completed. So none of that really shines in that tourniquets are bad. Nerve palsy, 5 patients suffered from this, all caused by injuries from the injury itself and not from the tourniquet, so it had no association with it. And venous thrombosis, 9 patients during their hospitalization, only 1 had a clot in the same extremity as the tourniquet. So that could be 1 out of 105 could be caused from the tourniquet, but you can't totally rule that out. But there was absolutely no loss of life or limb from the tourniquet itself. So that's a very good thing. That was a very positive thing from that study. Of the 10% that did not need the tourniquet, only 1 person developed complications during the hospital, and that was a PE afterwards. There was no renal, through this study, there was no renal injury, no nerve palsy, no compartmental syndrome, or a loss of life or limb that directly contributed to the tourniquet. So tourniquets have been proven to be safe. Remember though that uncontrolled from arterial bleeds can cause death within 3 minutes. What's our average response time in Lubbock, y'all think? Between fire and EMS, what do you think our average is?
3 to 4.
I would probably estimate about 4 to 5 to be realistic. about 4 to 5 minutes. And that's very fast because, guys, you talk to people nationwide, their average response time is maybe 13, 14 minutes. You look at like Fort Davis County down in the south. Anybody go down there fight fire? You're a long way from anything down there, aren't you? And you need help, and it may be 40, 50 minutes before help arrives. And so you've got to figure that this is something that has to be done quickly when we get there because they've already had their bleed time. And I don't know how many times we've right on scene, they're talking. We had one just the other day. The patient was talking on the phone to dispatch. The crew got there and they were in traumatic arrest. And so that can happen. And so we've got to think about those things. So enough of the numbers. Let's talk about the real stuff. So this was a crew that showed up on scene with a patient in his mid-30s at a correctional facility. He had been bleeding for approximately from both arms for approximately an hour and a half. So is our 3 minutes up? And then some. But staff there was trying to do the best they could. They were trying to control. They had already sutured the left side and they were able to control some of that. And then they were unable to control the bleeding on the right arm long enough to suture the laceration. So my question is, and Dr. Troutman, this is just me talking, but if I'm just going to suture externally and I'm still bleeding inside, suturing externally does me no good, correct? Because you still bleed internally?
So it would depend really on the size of the vessel that's got a problem underneath the laceration. So, even little fairly small arterioles can bleed quite a bit. Those you're not going in to try to microsurgically close together. You're just going to close over the skin wound and it'll form a clot in there, no big deal. But if you have a brachial artery that's severed and you just try to suture that up, what's going to happen? One, you're going to probably have decreased flow to the rest of your hand, and that becomes a problem. In a big vessel like that, we do want to end up vascular surgeons being involved to try to close, which I think that ended up being the case here.
It did. Okay, so staff on scene, they did apply a tourniquet to the patient's right arm for a short amount of time, but then they went ahead and released it, and the staff did not have the bleeding under control with direct pressure. So that's one of the first things we've got to always remember. If we've got something big, now, if I've got something big and I have to load and go, holding pressure may not always be my best bet. It's very difficult sometimes, especially in a moving ambulance, to use my knee to hold pressure in a junctional area while I'm trying to do other things. But if I commit one person to that, I've committed that one person to holding that pressure. So a tourniquet may be your answer unless it's a junctional injury and we need to pack those wounds. Staff advised that the bleeding was venous, but did squirt across the room hitting the crash cart. So I'm not for sure what total level this was, and we're not going to get into that because it's really not important. The important thing is that EMS walked in and we had a lot of blood and we had a problem, and we've had a problem for a while. Staff advised that blood was running under the door in the patient's cell when he was initially found. So this was a pretty significant injury, a long period of time. You would have hoped he would have clotted off by then, but they did a great job getting pressure on there immediately. As best they could. They went ahead and started addressing the issue. They did a very nice job in documentation. Even talked about 18 sutures on the right side, approximately 6 inches long. Really did a good job being very diplomatic with their documentation. Now, when we start talking about blood flow here, 1,000 to 2,000 cc's. That's a very difficult thing to guesstimate as a provider, especially when it starts to clot. You get a big clot clump and you're like, well, how many cc's you think that is? That's a hard thing. So they did a very good job. You're just documenting that there was a copious amount of blood. There is the two injuries, one of them just above the antecubical and the other one in the antecubical in the right area. This one was pretty much taken care of. This has been our problem child for the last hour and a half. So for bleeding for an hour and a half, we're really looking pretty good. 142/86. Heart rate's a little elevated. Well, they're poking and prodding, suturing, they're doing different things. He might be compensating just from that portion from the actual bleeding process. So once again, they use the bandage, 2 additional Curlexes. They start packing it on top, doing the best they can, get the cardiac monitor on, and then they finally say, you know what, we're putting a tourniquet on in place. We're using one of ours. Now, that's a good question. So if there was a tourniquet already in place, what do you do with it? Do you leave it? Absolutely. As long as it's an appropriate tourniquet. If they're using baling wire and it's a little bitty thin, that may not be the best thing, okay? I may have to make a decision to remove that. But if I've got something like a belt or a wide shirt and there's no bleeding, that may be a good part to say, you know what, hey, you did your job, it's doing a great thing. But at this point, if they would have walked in and they would have had a cat tourniquet in place and they were still bleeding, what do we do with that? Good, we get a second one. And also make sure to check that first one. Make sure to check that it is tight. Make sure to see if you can crank it down any tighter. And so that's one of those things just to think about. They didn't have this in this situation, but did they lose pulses? Yes. That is a big thing to say so we can make sure to eliminate compartment syndrome. So blood pressure's still good. Heart rate's ticked up 42 points. Why do you think that heart rate's come up now? Ouch, the tourniquets hurt, okay? And so they were running out of options. They got a guy that's probably getting really agitated. He's hurting, and we're adding more pain to that. So they did a great job by requesting intramuscular ketamine at 0.5 milligrams per kilogram. Now, why do you think they went to ketamine right here? What other options do we have that we wouldn't have to call for orders for? Fentanyl, nasally, and IM. But we think about those processes. Is fentanyl probably going to touch this cat? Probably not. So the crew did the best thing possible, call for medical order, because it's not in the protocol in this situation for IM. If it would have been, they would have been taken care of. They got their orders granted. They were able to give 0.5 milligrams of ketamine IM, which is going to be a slower release time, but it's also going to hang around a little bit longer as it's being absorbed. They got the ketamine on board for pain management. They went and chose IM. They got some oxygen, and blood pressure comes down a little bit. Heart rate reduces by about 30 points, so they've started making progress. The pain has been controlled with ketamine administration. Remember, we're getting a little bit of hypnotic effect with that, not a lot at that low dose, but a lot of pain management. Now, who's used ketamine at that low dose so far? Were they all able to talk to you the whole time? Half yes, half no, right? What'd y'all have? Who was over here? They weren't able to talk to you? They kind of put their head down and they were done? And so guys, that's one of those sweet things. Now, were they arousable? Could you wake them up? Okay. Could you wake yours up? Okay. And that's what that should be at this dose, is they should be able to have a conversation if you need them to. And we say that some people don't ever go to sleep. Some people stay active, but some of them, we want to make sure that we can use that for arousing. So what's the hospital outcome here? Patient was taken to the operating room, was intubated, and they repaired the large laceration of the right antecubical. A total of 2 units of blood was given. His H&H was 9.9 and 35, which is not a 75% reduction. But at the same time, that's still lower than below normal ranges. Normal range should be between 13 and 17 and 40 and 52 on the hematocrit. So he was also put on suicide watch for the next few days as that's what got him into this spot. So as you can see, guys, he did require a couple of units of blood.
Keep in mind that H&H takes a little bit to catch up. So let's say we just let this patient hang out for 6-12 hours, then recheck their H&H, it would have been significantly lower. You just open me up right now, dump half my blood out, and then check my H&H, close to normal. It takes a while for the hemoglobin and hematocrit to kind of redistribute throughout the plasma and what have you.
So you get it.
Yeah, so we often see a post-traumatic bleed, and you're like, why is their blood normal? Well, it's kind of a trick question we like to ask medical students.
Check it just a little bit and you'll see.
Yeah.
You'll see just fine. So as part of those process, they got a couple of units of blood, not as bad as we were initially thinking by what we were sizing up. So then the window attacked this guy. You know, it's horrible when these things happen. Gentleman was in his 80s, was walking, had a large laceration to the right upper extremity, but he denied hitting his head, he denied any back pain, any neck pain, and was very localized pain to the right extremity. EMS notes the family was very anxious and upset. Well, that's, makes your job a little bit harder from time to time, but they were able to give a clear medical history and stated that he was on Plavix at home, which can be a big bad problem for us. So he had stents placed. So guys, if I'm on Plavix at home, what all would they be using Plavix for? Stent placement, I gave you that one. What else? AFib. Well, if he has AFib, what other drugs could he be on? Eliquis, or he could be on a beta blocker, calcium channel blocker, something to regulate his rate. And so we've got to also add that into play, and because this was unknown of what other medications, because they were unsure at the time, because that's going to play into our factors. Now, we just did a screenshot because I wanted you to see the detail of what they documented of exactly what was going on. They did a spectacular job with this. Patient was alert and oriented with a blood-soaked towel that was draped across the patient's right extremity. They elected to go ahead with the cat tourniquet to control the suspected arterial bleeding that was coming from, and then once they got that put in place, they had loss of distal pulses. So very, very nice job with that. They remembered their C-spine clearance. They got their tourniquet in place. Once again, redefined exactly what happened there, and due to the color of the blood and inability to control, the tourniquet was placed. And so very, very good job. And again, pulses were lost. So they did exactly what we needed. Another assessment documenting their trauma. Approximately 30 seconds later, he regained. So they stood him up, transferred him over to the cot. They just did a little quick rotation. We had a syncopal episode. So what can we know right now? That's a positive tilt test. That's a poor man's tilt test, because I didn't actually tilt him, or I didn't listen for my blood pressure tilting him, but loss of consciousness, that's positive right there. Once again, they got bandages in place over the wound, cardiac monitor, IV in place. Blood pressure 102/58, heart rate 52. Is that concerning? Could be, but I've got to think, why is he on Plavix? Is he on it just for stents? Or is he on other, and even with the stent, even with the post-MI, those people go home with calcium channel blockers, beta blockers, sodium blockades. You don't know exactly what all's going on at that point. And so this may not be, he's not able to compensate for himself at that point, and that may be some of this. So they got their oxygen in place, they got some fentanyl on board. Once again, a great assessment, got an IV in place, started a fluid bolus. Now, were we at the blood pressure for a fluid bolus? By protocol, technically no. But they've done a great job because he's lost his ability to compensate for himself. So the crew, in my opinion, yeah, they didn't have the technical number, but they already had a positive loss of consciousness from a tilt test. So they put two and two together, did a great job here by going ahead and starting those fluids, in my opinion. Dr. Troutman?
Completely agree. And also remember, when we think about permissive hypotension, the bigger thing we're really thinking about is a blunt trauma, where we're thinking, is there a liver laceration or something, and we potentially displace that and the patient bleed. This patient, we know where they're bleeding from, right? And we have essentially manually stopped that. So I don't know that permissive hypotension is quite as important in this type of trauma.
And remember, with our geriatric population, their vital signs are different for hypotension than what we consider with our adult population. So great job by the crew. Technically, they didn't have the numbers, but they explained everything that they needed to do, which made it very, very appropriate. Continued with pulses. Blood pressure came up a little bit. Patient was feeling better. Once again, re-documented the CAT and how they did a very good job documenting everything. Smooth, rapid transport to the hospital. And what happened with this patient? So EMS physician documentation, patient was noted to have a brisk amount of bleeding when the tourniquet was taken down by the trauma team at bedside. So remember, tourniquets are those things that we do not want to be taking those off in the field. We want that done at the hospital. Directly to the operating room, 2 major lacerations, venous injuries. Remember that on the venous side, I don't have that ability to retract like I do with my arterial side that has the ability to somewhat withdraw. And so therefore I have an open water hose at that point. The laceration was deep through the muscle and down to the bone. H&H was 9 and 27. He required 2 units of blood, stayed 3 days, was discharged home into rehab services. So great job from the crew. And guys, that's why these protocols, sometimes I don't hit the exact number, but I explain what's going on. I had a positive basically a positive tilt test. I had a syncopal episode when I stood. He didn't have the blood volume to support his cerebral at that point, so they made a great job. They did a very good job of documenting that, covering what they were going to do, and made a good decision for this patient. Friendly reminders. If law enforcement or fire personnel use their tourniquet, EMS needs to replace their tourniquets immediately. So before that fire crew leaves or for that police officer, hey, here's one of our cats. Guys, they gotta have those. We don't use them very often, but when we do, man, we need them. And we want to make sure that, especially our officers, if they get injured, we want to make sure they have the ability to take care of themselves prior to somebody getting there. Fire, we need to replace theirs as soon as possible. And so hopefully we can get that done. If they ride in, exchange those out at the hospital. When in doubt about tourniquet use, try direct pressure first, but don't delay in tourniquet care. Remember, per Dr. Brooks, a lot of these tourniquets can go out 6 hours without any problems, and they can start to get weaned and get those off. Extremity tourniquets are not used to control bleeding for dialysis and fistulas. I can't stress this enough. Now, in an extreme circumstance, if this was a traumatic injury and you had a complete blowout, like you have the graft actually hanging out, that may be something you have to address. Apply direct pressure to that. A lot of those times, if those grafts are not sheared or torn apart, you can actually pinch those off very easily by just closing them.
I think the caveat there to remember, if this is just kind of a routine graft or fistula that's just bleeding, we shouldn't use a tourniquet. But if there was a trauma that occurred to the extremity, which happens to be in the general area of the fistula, then use the tourniquet. Does that make sense? And the reason we don't want to use a tourniquet is these things, as you know, you see patients that's got 2 and 3 different grafts because they clot off. They're at high risk to clot off, and they clot off when we put a whole bunch of pressure and cause trauma to them. So if we put a cap tourniquet on every little fistula bleed, it's probably going to be clotted off. Now the patient has to get another fistula, and then they got to have a temporary access for 6 months. It just becomes a mess. But if they fell through a window and it happened to cut their fistula, then yeah, use a tourniquet. So who here has put on a tourniquet on a patient? You have to put them on pretty tight, right? That's probably the biggest thing people are shocked at on how dang tight they have to be. It's you get it as tight as you can get it, you get the biggest guy there and they put it on a little tighter, and then that last little cinch, and then move the windlass. So have to remember that. I just wanted to mention again, I hope we all know this. Do we put tourniquets on snake bites? Heck no, we do not do that. I know that was mentioned early on in this presentation, so I thought I just want to throw that out there. We already covered if it is something, even if it's a homemade, if it's a belt or a shirt or it's another brand of tourniquet and it's working, don't replace it, right? Now, if there's an extension cord tied around and you use baling wire, we're probably more apt to see that around here, maybe then do replace it. Because remember, you got to have some width. If you're putting a piece of wire or just an extension cord, you really don't have enough width. And if it's not bleeding and you've got an extension cord around there, it probably didn't even need a tourniquet, right? But in that case, I would remove it, take a look at things, and then place our cap. I think that's it. So both these cases, when we kind of talked about, I mean, everything was spot on and very extremely well documented.
So talking about our mass casualty, we're going to talk about an accident that was on the interstate. And guys, we've got to understand, it doesn't take 3 or 4 patients on one call to really start stressing our system, especially if the city's at its normal capacity. And so a lot of times that may leave you guys working a little bit longer on a patient if we've got extra trucks coming, because they may be coming from a long distance, just depending on what the call volume is through the city. You look at the simple thing as the Boston bombing. That went from everybody just running to complete chaos. I got to listen to the first paramedic on scene talk about that call, and it was very fascinating, his thoughts and his processes of what had to be done in a very, very short amount of time. So an MCI is a term that we use for major disasters, which can be car wrecks, weather, it could be a lot of different things. But there's no preset number to that. There's no preset number to say at this many patients it becomes an MCI. Mass casualty incidents a lot of times overwhelm the local resources. As y'all can see, sometimes, guys, like I said, it does. If you have 4 criticals on scene ejected or 4 people from a gunfight, that's a big stressor on the EMS system immediately. And you think about our county partners. You think about something bad happened in Idalou or Slayton or Abernathy. I mean, how long, or Shallower, how long is it going to be for help to get there? You're going to have your hands full for a long period of time. And y'all don't always have the resources to have Lubbock Fire immediately there that are ready to go and boom right there. You maybe have to wait for a volunteer service. And so this can change what may be an MCI in Lubbock may not, or may be an MCI in Abernathy, may not be an MCI in Lubbock. And that's part of those processes. It has to stress that local system. But we want to make sure that we're also talking about our IMS, our incident management system. And this is something that we use probably a lot now. A lot of crews are very good, and I love to hear this, but they get on scene, they say, have 1 green trauma, 1 red trauma. If you will get in that mindset of using it, some people say, well, that's kind of silly. And it kind of is on if it's just 1 patient, I've got 1 green trauma, but it gets your mindset for when something bigger happens. You're already used to saying, here's what I've got, and people are going to start keying off. The chief's going to hear, oh, you got 2 reds? Somebody better start heading that way, and we need to start working on some resources. So we're going to talk about a multi-vehicle accident here in just a second. UMC defines our IMS as anything with 3 ambulances or more that are needed for transport, okay? You could have 6 patients going 3 ambulances real easy. You could have 3 patients, or actually, you could have 2 critical patients go by 3 ambulances because it may take another ambulance to ride in, or you take an engine or ladder crew out because they're going to have to ride in to help. So that's going to definitely stress the system. One of the things that we would like to make sure that we talk about, even in the IMS system, is effectively communicate. Early incident command structure. Hey, I'm first on scene, and you may say, I'm a paramedic for 2 months. It's okay. It's okay. You get there and say, I'm incident command for now. My partner's doing triage. I'm going to start getting what I need. Just by sizing it up, I see I've got these 4 patients here. Go ahead and start me at least a 211 and maybe a 311. Be incident command, but be a good communicator. People have got to hear you, including the chief, of hearing what's going on, and that helps them start to manage. Because if you said I've got 4 reds, and the chief doesn't ever hear that you had a 211, he may say, oh, you're overwhelmed. Dispatch, we have 211 going. Just double check. There's nothing wrong with that. Interagency cooperation. Guys, you're going to see on this wreck, Lubbock Fire did a fabulous job of managing because there was trucks coming from, one came, I believe, from UMC and the other one came from across town. So these guys had their hands, we had our hands full with 2 patients. They had 2 other patients that they've got their hands full of managing those patients until more help can arrive. The first on scene needs to establish EMS command. So whoever it is first, I have been on a major accident right outside of the city limits of Lubbock. I was the first truck in and did not transport anybody. That can happen from time to time. We want to try to prevent that because it's a wasted resource on scene. But if I've got a bunch of VIN codes, that could definitely happen. And people are saying, oh, dude, that wasn't cool. I got stuck with it may happen that way, but you got to see what are the needs on scene, and you just got to kind of tag that up. So tag you're it. Who starts it first? My partner's going to start rapid triage. And guys, this may be, yep, you're not breathing, you're breathing, you're breathing, you're breathing, you're bleeding. Okay, but you're breathing too. So I've got room, my partner's got to be quick, and then we've got to understand, I've got to be able to communicate that back. Now, I'm not saying that you as the first provider, as instant command, can't do some triage with it. You've got to be able to get up there and help and say, okay, I'm going to take these 2. If you'll take those since it's over there, I can manage these 2. Let me know what you need. A lot of times you'll hear us on scene. You'll hear one partner say, I need a 211. Another partner say, I need a 311. As long as y'all are in close proximity and we're looking at each other, James and I are looking and say, hey, I've got 2 here and you got 3. Okay. He hears me. I hear him. I know we've got something coming. Soon as the supervisor gets there, dump that off. Guys, I promise you don't want to be incident command for long. Les, is that true? As much MCI training as they've had over the last 6 months, you don't want to be the incident command very long. Push that off on somebody else, because if it goes bad, it's coming back on them. So give it to somebody else. That way you can start your process and start treatment and transport. The big concern during the MCI is protected patient information. We understand sometimes that you don't want to put people in the same ambulance together. But if it comes to a point where that's the last truck, and we are completely out of trucks, you're going to be waiting on somebody to transport, get to the hospital and come back, that may not be the best thing. You can, by HIPAA law, put 2 people in the back of an ambulance. We've done it for many, many years. Who remembers in here when we could haul 4 patients in an ambulance? Yeah, we used to have hooks in the back and we could hang them. And we would have patients stacked everywhere in the back of the ambulance by the backboards. That's old school days. And so that was way before HIPAA really came out. So I wouldn't suggest that in today's world. We like to try to keep family together if at all possible. You know, if I'm going to UMC, I want my family to go with me. If somebody else of my family says, no, I want to go to Covenant, so be it. An ambulance can make multiple stops. That's just fine to be able to do that. Take your most critical first. Two key things during an event: implement reasonable safeguards when transporting multiple patients. I don't need to say, Alan, what's your date of birth, your social security number, and your past medical history? This may be something I need to lean down and say, I can get most of this information, but what's your name right now? I'll get the rest of my stuff later. Are you on any medicines that cause you to bleed? Simple things like that. That's something I can be very quiet and discreet about. Disclose only the minimum amount of healthcare information that is absolutely needed at that time. I can get the rest of it when I get in to the room with that patient in private. Room 1 and 2 at UMC. That little curtain, that doesn't stop a lot, okay? There's a lot of stuff going on now. It's a lot of chaos sometimes. So you may not hear what the other side besides just noise, but sometimes that's going to happen. You're going to have multiple patients together. When an ISM or an MCI, it overwhelms the system, you may have no choice but to transport more than one patient. Within reason, HIPAA allows us to have some disclosure if we use common sense with that. When requesting information, lower your voice. Ask for only the minimum necessary information. And guys, this may be something good to where I can say, hey, can you get their medical information real quick and I'm going to get this one? Because if he's talking and I'm talking at the same time, they're not going to be able to listen both ways. So that may be a good time for us, if there's 2 people in the back, to handle it that way. Keep patients' records out of sight when possible. That's something we should be doing all the time. What not to do. In your trauma room voice, and y'all know what that is, we can giggle about it, we do not want to announce protected healthcare information. PHI should be disclosed to people that are directly taking care of the patient. Please remember that we don't want to use Facebook. Why is there a policy written about that? Because it's happened, unfortunately. Don't limit your patient care because you're afraid of obtaining more than a name and age due to HIPAA concerns. Take care of the patient, okay? We understand there's only one heart monitor on that truck. That is understandable. So if I've got 2 patients, maybe a 31 and 1, and maybe I'm taking a 30 and 1, and I say, you know what, if you're having chest pain, I really need a heart monitor, so be it. I may have to put it on this one for a little bit, because if that's the only truck available and that's all there is, I may have to move it over. Or if the Fox truck is there, grab the AED and switch it over to the 3-lead. So you've got different options that can be available. We've done this for many, many years and we haven't had too much problem. So we're going to work our way through this MCI real quick. So this occurred 10 minutes ago. It was a rollover on the interstate and the patient was ejected from the vehicle. This is a high-speed rollover, and it was only 1 car involved initially is what they thought, and there were 3 patients that were considered critical. So this is our first patient that was laying there, had an unstable pelvis. Blood from the nose, loose teeth, large avulsion with a depressed skull above the right eye, large avulsion to the left eye, swelling to the orbit. As you can see, I mean, this patient is confused. There's a lot of different things going on here, a lot of different systems from this multi-systems trauma. So fire was the first on scene. They located it first. They did a great job getting a C-collar in place. Even though that there was a long spine board, they had placed the patient on a long spine board, which is plenty appropriate. We used it to move. And you know what? The crew did a great job because this patient was critical and it wasn't the time to try to get them off of that board. We needed to go to the hospital. Those can be one of those times when you can say, as a provider, okay, I've left them on the long spine board because of patient safety. I made that decision to say it's okay to do it at this point. Now, we know the best literature says get them off of those spine boards as soon as possible because of step-off fractures. You got a lot of different issues that can take place. Skin breakdown, how long are they going to be on the board? If they vomit, what's going to happen? We've got problems. We get them in the back of the truck and we've got good stable vital signs, not tacky, good here. And they placed the patient on oxygen. They were unable to attain more than 2 sets of vital signs due to the patient having emesis in the airway. This paramedic made the decision at this point to take a fireman and to go to the hospital. That was the best choice at that point because you had lots of patients. You had minimal trucks available. And as you're going to see in a minute, fire was left with one of them for a lengthy period of time because another truck was coming. A non-rebreather was placed. Suction was used throughout the call to keep the patient SATs above 90. They got an IV on the way to the hospital. Cardiac monitor was in place, a secondary IV, and you're going to see fire did a great job documenting about this. So this is fire's report, and I had to read this because I'm not used to y'all's reports as much, so I had to really read through this. But as you can see, nobody was entrapped. They did a great job talking about the red vehicle that was up on its top, very descriptive with what exactly occurred. Talked about everything. EMS personnel, the C-collar was placed on her. They made the decision at that point, log roll. They got them on a spine board, got them ready to go. At that time, EMS arrived, requested us to accompany them to the hospital. That's great. Had an unstable pelvis, had teeth broke, and they established some IVs on the way to the hospital. And it ended up that the paramedic sat at the front literally and had to suction emesis out of the airway the entire time. Now, the LOC was not that great on this patient. The hospital documented it as a 6 on arrival. The question comes in, does that patient need to be intubated? Well, you're in the back of a truck with a 6 or 7 minute transport time by yourself. As the paramedic, you have an advanced provider, which gives you another set of hands for intubation, but are you going to be able to get to drugs? Their 2 fire were down there. They were starting lines. Who's going to be able to get down there and push? Who's going to be able to intubate? It just may not happen. So what they did is they did appropriate thing and they suctioned the whole way and kept their stats at 96%. Just because an LOC is low doesn't always mean that we have to get that intubation. It's a protected airway issue, yes. I may need to protect their airway. But just because I have a GCS of 6 or 7 doesn't always dictate that that is the best thing for the patient at that time. We always have to remember that anytime we choose to take somebody's airway, there's an associated risk with that. I'm betting that patient's life on my intubation skills. An obvious head injury with a GCS of 6 was intubated due to mental status with emesis in the airway, extubated the next day. Radiology had a frontal bone fracture, extended through the frontal sinus, no spinal fractures, a small pulmonary contusion on the right lung, ended up having a coup contre coup injury to the temporal and the frontal occipital lobe, and antibiotics were given for the sinus fracture. Patient reported knee pain once she was extubated. Radiology found that, and so you can see this is a couple of days down the road, we had a patella injury, and they discharged her 7 days home. That was a great job by a combined effort of great care at the beginning, and then followed care through the hospital, and then gave great care at the hospital to get that patient to have a family reunion. So there's a picture of, there's a 3D reenactment, and there's the knee issue. Second patient from this is in her mid-20s. Once again, she was ejected as well. And we'll keep the rest of these pretty brief because there end up being 4 patients from this. Did a good job, got a golf ball sized hematoma. Patient had abrasions down her left side, so she had some road rash. She had abrasions in her left elbow. Once again, had a little bit of blood loss, typically less than 100 is what they said, but had a pretty good laceration inside of the left knee, so that can definitely cause us a problem. But then we think, ooh, 80/0, because we just palpated it, which is perfectly appropriate. We had good heart rate. We had good saturations. Made the decision to load this patient and go. Second set of vital signs, 97/71, a little bit of improvement. Patient was lying secured to her backboard. So once again, this is the patient that fire ended up having for a little bit. We had a truck coming. You only got 2 paramedics initially there on scene. They're going to be spread thin. You guys stepped up to the plate, did a great job. Got the C-collar on, got the patient ready to go. Basically, when EMS got there, put them on the cot, and boom, we're out of there. If they wouldn't have got this far along in the process, then we got to get there and we've got to put them on, and it just takes time. They did a great job right here, moving quickly to get that patient to the facility. This is fire's report again. They documented, once again, a rollover that was on its top, possibly ejected, had 3 patients on scene, did a very good job documenting the laceration. Heart rate was all documented well in their report, exactly what they all did, that they got them on the backboard, we were ready to go. As soon as the EMS got there, we transferred to the stretcher with the head slightly elevated, and boom, we're gone. Rode into the hospital, taking care of this patient as well. Hospital outcome, she ended up having a C6, C7 teardrop fracture, and we'll show a picture of that here in just a minute. She underwent surgery for that. That's what a fusion looks like. So if you hear people that say I have a neck fusion, this is an anterior approach. So they went in from both sides of the trachea and esophagus and worked, and that's what a fusion looks like. That is what I call a rail. And sometimes they'll have to run these rails all the way up and down. And so that's what that looks like. Left knee injury, an MRI. She ended up having an ACL and a medial meniscus tear along with everything else. So when we start talking about a teardrop fracture, because you may hear the doctors say, have a subluxation, have a teardrop fracture. This is the teardrop. This is the anterior portion. You can see the process there is broke. They actually have a tear in the cartilage in between the external process, or the processes on the back, which is going to actually cause, and you've got the step off right there. And so when that pulls up on CT, that's putting pressure on that spinal column. That's where we're going to have those issues. There's a good look post-surgery, getting it fixed, getting everything squared up, tightened up, and that's what it ends up looking like from an anterior view. The third patient was in the mid-30s, was a backseat passenger on scene. They were traveling down, once again, the interstate at a high rate speed, thrown approximately 40 to 50 feet from the vehicle. And the patient said initially that she was breathing. Bystanders said that she was breathing on their arrival and was positive loss of consciousness, and then started to cry out. Lubbock Fire was on scene, placed the C-collar. Once again, guys, these guys did a good job. I think y'all ended up having 3 engines there, so y'all had a lot more manpower spread out. They did a great job getting everything backboarded, ready to go. EMS got there, loaded them up, and they boom out the door. Pressures were good, GCS good, blood glucose, everything looked pretty good. Did a very good job documenting everything that they found. Bony process, had no damage on visualization of the right eye. Around the right eye, they were able to get a really good look at that, of the injury. Patient was noted to have an avulsion to the right side of the forehead. That's why they were able to get a good look at that bony process. Interventions, once again, got IV, got fluid, sinus tack, pain management, Zofran, to keep that. Guys, remember, anytime we have an ocular injury around the ocular, we sure want to keep them from having emesis. That's going to increase our ocular pressure, and which is going to cause more problems. So at the hospital, they found a frontal head laceration, a left elbow laceration. It was repaired in the ED. She ended up having an L4 transverse process fracture that did not need surgery. She was put in a telso splint, which is a full body torso splint, and they'll wear that for usually a couple of months. Anterior sacral wing fracture. That was no surgery to do that. She was admitted overnight and then discharged home. 20-year-old male that they were on scene. Fire actually made first contact. He was walking around. They started sizing him up, and he said, I don't feel all that great. I'm hurting a little bit. Made the decision to go ahead and transport to the hospital. He was seen in the ED, had no fractures, was discharged home with just a contusion. So the summary was one vehicle rollover with 3 fire units, several, of course, a lot of police, 5 UMC ambulances, and 2 Fox trucks responded. You can see this stressed the system. This happened at night. So that left just a few additional units that were still running the 911 calls and kept everybody very, very busy. 3 of the patients were transported 31 and 3 with fire's assistance, all of them being unrestrained and ejected. They had one that was 29 and 1 and then one that was refusal on scene. The total amount of time from the time of call till everybody cleared the scene was 1 hour and 7 minutes. So you can see for 1 hour and 7 minutes, that sure stressed your system, especially at night.
Well, I know we're out of time, but just a couple things I really do want to mention. One thing, sometimes I've been asked the question, okay, well, we have this MCI, we've got 6 patients, EMS is transporting 3. Can we just throw this other guy in the engine or in the Fox truck? He doesn't need a backboard, but I've got his arm split and just take him to the hospital. So the official answer to that is no. You have to be licensed. An ambulance is licensed by the state to take a patient from point A to point B whenever they request 911 service. And these typical MCIs, that really should never happen. Now, if a building fell and we have 47 patients that need transported, sure. If people's pulling up, you can throw them in the back of the cars. You just get them to do whatever you can do. The state and everybody's going to overlook that. But this type situation, we usually can still provide care to the patient and continue to stabilize. But just, I know I've been asked that question, why can't we just do that? That's not my rule, that's not our rule, that is a state rule. So the first patient, we talked a little bit about should they have been intubated. And one of the things we often, unfortunately or unfortunately, have to do behind the scene is we get the inquiries from trauma and from the ER saying, why didn't you guys do this? And an inquiry came out on this patient. Why didn't y'all intubate this patient? Their GCS was low. And this is where documentation is really important, because the first thing we do is go back and look at the report, because we always want to be behind you guys. We want to be able to say our crew did the right thing. And most of the time we can do that, but that's supported by our documentation. So, could the patient have been, let's say this patient would have been intubated by us, I think that would be okay. I think what we did was okay. We documented good stats. We documented that we were on that airway, and we were also just limited on our hands, right? We didn't have 3 people in the back of the ambulance to help us intubate. So a lot of times we have to have those conversations with M&M or the ER. They just want to understand, well, why didn't you do this? And as long as it's reasonable, and this was reasonable to not intubate, then it's fine. Another thing to remember, I think every single one of these patients went to UMC. Covenant has similar trauma capabilities. We don't just like we get overwhelmed in the field, a hospital gets overwhelmed at some point too. So don't forget, spread the love sometimes, okay? And I just want to mention, the spinal boards, and I think the patient that ended up having the cervical fracture, we actually rolled off the spine board once we got into the ambulance. They still had a collar on, assuming they had some tenderness, but notice they were fine, right? So backboards, again, I think did a right job. You got people flung out everywhere, get them on backboards, we can move them from point A to point B, but then when it's safe to do so, get them off those spine boards.